So I'll begin by introducing the speakers. Dr. Maureen Markle-Reid is a professor emerita in the School of Nursing at McMaster University and a Canadian Academy of Health Sciences Fellow. She is the founder and former co-scientific lead of the McMaster Collaborative for Health and Aging and the Aging Community and Health Research Unit. From 2012 to 2022, she held a Canada Research Chair in Person-Centered Interventions for Older Adults with Multimorbidity and Their Family Caregivers in the School of Nursing at McMaster University. She is known internationally for her work in designing, implementing, evaluating, and scaling up complex and integrated patient-oriented interventions that have significantly improved the outcomes of older adults with multimorbidity and their family caregivers. Her research findings have influenced practice and policy, as well as national best practice guidelines to promote optimal aging. She has contributed to stroke care in Ontario and Canada in a number of ways, including several large pragmatic trials of innovative community-based stroke rehabilitation delivery models, participating as a member of the Best Practices and Standards Working Group within the Canadian Stroke Network, participating as a member of the Vascular Cognitive Impairment Council with the Heart and Stroke Foundation of Ontario, and participating as a member of the Scientific Review Committee for the Heart and Stroke Foundation Grant and Aid Research Fund. Eileen Britt is a physiotherapist and is currently serving as Regional Stroke Rehabilitation and Community Coordinator for the Central South Regional Stroke Network. David Daler is the co-chair of the Central South Stroke Network's Patient and Family Advisory Council and a patient partner in Dr. Markle-Reid's research. So welcome, Eileen.
Thank you, Tina. We're very pleased to present today for these provincial stroke rounds. As you can see, our objectives for our session today are to learn about the effectiveness of the Transitional Care Stroke Intervention Study, or as we short form it as TCSI, for improving the quality and experience of hospital-to-home transitions for our persons with stroke and their care partners, to learn about the barriers and facilitators to implementation of the TCI in 2 of our Central South sites, to discuss how the results of this TCI study can be used to improve transitions and advance stroke recovery, self-management, and community reintegrations for persons with stroke and their care partners. And finally, to discuss the implications of the results for our implementation and the possible scale-up of the TCI in other provincial regions. The opportunity to present to you today is timely, given the work being undertaken on the Provincial Community Stroke Rehab Initiative that many of us are familiar with and involved in. Today, we're pleased to share with you that to further the research and possible impact of the TCSI study, we're aware that the McMaster Research Group is closely collaborating with Ontario Health Core Health to conduct a scalability assessment of the TCSI in Ontario, and for these results to provide information onto how to best adapt, implement, and scale up the CSR provincial initiative. There will be an opportunity for a few sites to participate in this assessment in the future. The Canadian Stroke Best Practice Recommendations define transition as the movement of people across various healthcare locations, settings, and providers. We know it should include working with persons with stroke, their families, and caregivers to establish and implement a transition plan that is inclusive of goal setting and has the flexibility to respond to their evolving needs. The best practices go on to define successful transition as having the transfer of accountability occur through interdisciplinary collaboration and handover. Ideally, we speak to warm handovers between providers, always with the person with stroke, and their family and caregivers. It encompasses the organization, coordination, education, and communication required as people move through the various stages and settings of their stroke treatment, their recovery, their reintegration, their adaptation, and potentially end-of-life care. And it's really important to keep in mind that successful transition planning includes discharge planning. Recognizing these best practice guidance references and keeping in mind the definition of successful transition that I've just shared with you, we'd like to share with you David's stroke journey and his transition experience. David, could you describe for us your stroke journey to tell us how you got to where you are today?
Well, it was somewhat of a bumpy road. I had my stroke just about 6 years ago, and the day I had it, we went to the hospital, and I was misdiagnosed at that point and sent home. And it wasn't until the next day that I went back again and was admitted. It hadn't shown up on the first CAT scan, and it did show up on the second CAT scan. So I was then entered into the system. So I was hospitalized in an active acute unit for a couple of weeks, and then to a rehab unit in hospital for another 2 weeks, and then was released, and then got into an outpatient rehab program.
And how long in between your inpatient rehab and your outpatient program?
It was just about a month, I think, from the time I left the hospital. Yes, it was almost a month.
And did you have any communication in between?
No, that was one of the bumps along the road. From the time I left, when I left the hospital, I really had no idea where I was going, except that the physios there had recommended applying for the outpatient program, and they helped me with that. So I did that, and then I just had to wait. So actually, in between times, we did book some private physio. So I went to a private physio clinic to do some rehab before I got into the outpatient program.
Great. And then once you started your outpatient program, can you highlight for me how the transitions were for you? Could you share with us the good, the bad, the bumps that you experienced? I know I've just highlighted a little bit, but could you give us a little bit more of some of the details and how you felt, what your experience was?
I think to understand that, we'd go back a little bit. When I entered the system, when I had the stroke, I was a 68-year-old man, healthy man, never really having been ill. So at that point, I was thrown into a system that I knew nothing about. So it was like being in a country and not knowing the language, not knowing anything. So there was no mode of communication. And the communication really wasn't good at that point. Now, there's been a lot of strides made since I had my stroke and now. And we'll talk about that a bit later, I guess. But I felt very disconnected, and now every stroke is different. No two strokes are the same, but every stroke patient experiences anxiety and nervousness and fear, and that's what I was feeling at that time. So when I was coming to the end of the in-hospital program, I had no idea what was coming next. I knew where I wanted to go. I knew what I wanted to do. I didn't know how I was going to get there. I didn't know if I was going to get there, or what would need to be put in place for me to reach those goals. So that was a bump along the way. But to the credit of the people that I was working with in hospital, they were very helpful about what I could do. And when I got to the outpatient program, I was fortunate enough to get involved in a study, and that study was a study that engaged the clinicians and the practitioners and the therapists with the patient on so many different levels, in home, in the hospital, and in the community. And so it gave me a comfort level that saw the transition work much smoother for me once that happened. But until that time, it was really floundering.
David tells of the bumps, and his story illustrates some of the problems persons with stroke experience as they journey through their stroke recovery. Our system of transitioning across the full stroke continuum is not working as well as it should, and we have work to do. The abrupt and complex nature of stroke and the limited length of stays in rehab result in an intensive window of time for persons with stroke and their care partners to prepare for the challenges of returning home and to their community. We are certainly aware that improvements in hyperacute and acute care have contributed significantly to a decline in stroke mortality. However, despite these improvements, and even with the presence of evidence-based guidelines for community-based stroke rehab and transitional care, we continue to have gaps that exist and persist, and the burden of stroke is increasing, especially in the post-acute phase. Most, around 58 to 60% of older adults, are discharged directly home, and after their hospitalization, up to 60% require rehab in the community to further support their continuing recovery and their reintegration to their life post-stroke. Navigating the transition between hospital and home is associated with substantial psychosocial and health-related challenges. And we're all very aware that just the hospital to home transition is not the only transition that many of our persons with stroke will experience. The median number of transitions after discharge from acute care that our persons with stroke experience is around 3, and some will experience up to as many as 7 transitions in their first 90 days post-stroke. We recognize that these deficiencies in quality of transitions and the significant evidence gaps regarding stroke care transitions can have significant consequences. So why is this important? We're truly aware that poor quality transitions from hospital to home can be associated with avoidable hospital readmissions, increased healthcare use and costs, reduced quality of life and patient satisfaction and safety, and the additional increased stress and burden that's placed on the care partners that are caring for our stroke persons who have returned home. So what are some of the factors that we're aware of that contribute to poor quality transitions? We do see a few themes. One tends to aggregate around communication and collaboration. We can hear and do hear of poor communication and collaboration amongst providers, both within and across the various transition settings. We hear of conflicting plans of care and instructions. We've heard stories that patients and their families haven't been involved from the beginning in decisions around their care plan. And we are also aware of the lack of education that can occur during or after their hospital stay. We hear about access issues, that suboptimal use or delayed access to outpatient stroke or other community stroke rehab has been the experience of many of our stroke persons, that there's lack of timely follow-up with specialists and their family docs, or there's just plain difficulty in accessing services. We're aware of lack of individualized self-management plans or information available about community services. And we're very aware of wide variation in services due to the lack of standardization of our community-based stroke rehabbing programming. So just what should we be striving for to achieve successful transition management for our persons with strokes, their families, and their care partners? Best practice recommendations advise that the goal of transition management is to facilitate and support seamless movement across the continuum while striving to achieve and maintain optimal treatment, outcomes, adaptations, and quality of life. And it covers a spectrum of physical, cognitive, emotional, environmental, financial, and social factors. Recognizing this goal, what can we be doing? Effective, equitable, scalable, and adaptable models of integrated care are needed to improve the experience and the quality of transitions across the stroke care continuum for persons with stroke and their care partners. One such model we're happy to share with you today is the Transitional Care Stroke Intervention Study led by Dr. Marco Reed from McMaster University and the Aging Community and Health Research Unit. This study was co-designed with patients, care partners, and providers in collaboration with our Central South Stroke Network. Dr. Marco Reed, over to you.
Thanks, Eileen. It's great to be here today. Just wanted to start off by acknowledging all of our co-investigators on the study that are listed here on the slide, as well as that include our 5 patient partners, which include David, who is here with us today. And all of these partners brought their lived experience to the research. Next slide. So this is a list of all of the various partners that we engaged in the research, and they represent local, provincial, and national organizations. And I just want to highlight that the partnership that we had with the Central South Regional Stroke Network, as well as our partnerships with the Regional Rehabilitation Center at Hamilton Health Sciences and Hotel Dieu Shaver Health and Rehabilitation Center, who served as sites for our study. Next slide. So this slide shows you our governance structure for the study, and it was developed to strategically engage the study sites. So we had 2 study sites and their organizations, and also to engage our co-investigators, other partners, knowledge users, patients, caregivers, providers, and policymakers. And I want to really highlight that patients and caregivers were co-investigators on the study and integral research partners, and they were embedded throughout the governance structure. So we had a steering committee, and that consisted of our knowledge users, our co-investigators, which included policymakers, as well as patient research partners, and also trainees. And the steering committee met twice a year via teleconference or web conference and provided guidance in all of our research directions. So they provided oversight for all of the study activities. Then we had regular monthly meetings with the interventionists. So those clinicians and managers who were actually involved in delivering the intervention. And those clinicians and managers came from 2 sites, Hotel Dieu Shaver Hospital, which represented the Niagara region, and Hamilton Health Sciences Regional Rehab Center that represented the Hamilton region. We also had regular monthly meetings with our patient research partners who advised the research team on a number of issues, such as recruitment, development of study materials, the types of outcomes that we decided to use to measure, just to name a few. So next slide. So this is an overview of our transitional care stroke intervention. This was a 6-month intervention. It was integrated and patient-oriented, and it was designed to improve both the quality and the experience of transitions from hospital to home and from formal community strokes rehab services to community reintegration by enhancing self-management. The intervention was grounded in best practices in transitional care, community-based stroke rehab, community reintegration, and virtual care, as well as we use self-management theory. The intervention was offered in addition to usual outpatient stroke care, and it was delivered by a specialized interprofessional team of clinicians that were experienced in stroke and stroke rehabilitation. And these clinicians consisted of a registered nurse, an occupational therapist, physiotherapist, speech-language pathologist, and social worker from each of the hospital settings. So we had 1 team per site. The TCSI was coordinated by a dedicated stroke care coordinator navigator, and the intervention consisted of 6 core components. The first component is that the care coordinator navigator conducted a follow-up phone call to participants 2 to 3 days post-discharge. And during that phone call, they conducted a brief assessment and completed the patient-oriented discharge summary. The next component was that the team offered each of the participants up to 6 virtual visits, and those visits were conducted either by phone or by web conferencing, depending on the preferences of the individual. The next component was that the team met on a monthly basis and conducted a care conference where they discussed each of the patients and developed a common patient-centered plan of care. The next component was, as I mentioned, there was a dedicated care coordinator navigator for the team. And the final component was that all of the participants had access to a website called My Stroke Recovery Journey. And the idea of this website was to support care coordination and system or service navigation for individuals with stroke as well as their care partners. So the teams developed an ongoing relationship with usual outpatient stroke clinicians, as well as other community care providers, to ensure that there was continuity of care delivery, transfer of care information, as well as transition planning. And prior to implementing the intervention, we conducted a gap analysis to really understand the gap between existing clinical practice and the TCSI. And we used that information to develop a standardized training module for each of the sites. And then we adapted the training to the specific needs of the providers and the organizations within each of the sites. So next slide. So this slide, as I mentioned, the My Stroke Recovery Journey website was a key component of the intervention. And the Community Stroke Journey Map, the paper-based version of the Community-Based Stroke Journey Map developed by the Central South Regional Stroke Network, led to the development of the website. So I recognize that many of you have a journey map, and we recognize that our journey map, at the Central South Journey Map, is built on the work of others. However, the next evolution that we found of this journey map was to digitize it. Because it was a virtual intervention, we decided to digitize the map. And the idea for this actually came from our own patient partners. And it was led by and co-designed by our patient partners, who were also members of the Central South Patient and Family Advisory Council. So they recommended that we use the paper-based version of the My Stroke Recovery Journey map as a framework for the website. So we worked in collaboration with the network and their advisory council and our own patient partners to co-design this website, which was designed to start a conversation between a provider and a patient at any point in the care continuum, to support self-management and goal setting, to provide an overview of the stroke recovery journey, discharge needs, and also people could anticipate what's next in their phase of care, and to provide access to updated resources and available community and health services at each point in the continuum. So we actually embedded links to all of these various services within the journey map. So next slide. So this is a tutorial that is actually part of our website, and it's only a snippet of the tutorial, but I thought we would show you this so it gives you a sense of what the website is all about. And at the end of our slide deck, there's a link to our website, so you're welcome to go in and explore it. So I'll just ask you then to start the tutorial.
Welcome to our tutorial video. This is the home page of our website. It displays the map and provides an option for you to download your own copy. This document can be edited and saved on your computer and printed. You can check the boxes, fill in the information, and take personal notes. Let's talk about some tools that could be helpful while using the website. Firstly, you can access accessibility features by pressing this navy circle icon on the top right corner of the page. You can use this menu to change the contrast of the website, enlarge the space and the text, and enlarge the cursor size. If you press the cursor button twice, you will open a reading mask, which may be helpful to focus on small parts of the text at a time. To undo any of these changes, we can press Reset All. If you would like to have the text read out loud, you can highlight the text that you'd like to be read. This is done on the computer by holding down the right button of the mouse and dragging it across the text. Once the text has been highlighted, a speaker icon will appear. Click or press this icon to have the voice read the text out loud.
Click a stage on the map to learn more.
Okay, so it's a fantastic video. I encourage all of you to go on the website and explore it a little bit further. So the next slide shows you that the study the TCSI study was built upon the results of a pragmatic trial that we conducted that showed that a specialized stroke interprofessional team resulted in greater improvements in physical functioning among older adults with stroke receiving home care compared to usual home care at no additional cost. And the results of it also built on the results of our feasibility study that we conducted a few years ago at the Hamilton Health Sciences Regional Rehab Center, which showed that the TCSI was feasible to implement in real-world practice and resulted in a reduction in hospital readmissions and emergency department visits for any cause. So next slide. So the objectives for the study primarily were to examine the effectiveness of the TCSI compared to usual care on health outcomes and costs among persons with stroke and multimorbidity. And our secondary objectives were how to best implement the TCI intervention across the study sites, and also to examine patient, care partner, and provider manager experiences with the TCSI intervention. And I just wanted to mention, and it's important to mention that this study was initiated and conducted during COVID. It was actually initiated 7 months after the COVID pandemic was announced in March. So the study started in December of 2020 and carried on for a total of over 11 months. And this had significant implications for how the study was designed and implemented, which we'll address later on in the presentation. Next slide. So the first objective was to look at what is the effectiveness of the TCSI compared to usual stroke care on health outcomes, patient experience, and health and social service unit costs among older adults with stroke and multimorbidity. Next slide. So this study was a pragmatic randomized control trial. And pragmatic essentially means that we conducted the research within the real world using the existing resources and providers. And the other part of pragmatism includes the recruitment of participants that were representative of the population that are presenting in the outpatient clinic, as well as being flexible in the delivery of the intervention by the interprofessional team, and using what we call patient relevant outcomes, which we'll talk about in a moment. So eligible and consenting participants were identified by a trained recruiter who was actually our care coordinator navigator that took on that role. And then once the participants were deemed to be eligible and consented to participate in the study, they were randomly assigned to receive the TCSI plus usual care or usual care alone. Data was collected prior to randomization and again 6 months later by telephone using interviewer administered questionnaires. So what we were looking for was the change in outcomes over time. Next slide. So this slide shows you our eligibility criteria for the study. So in order to be eligible for the study, participants had to be 55 years of age and over, hospitalized for a stroke within the last year, had 2 or more chronic comorbid conditions in addition to stroke, discharged to the community, but not hospital or long-term care, referred to outpatient stroke rehab within the 2 study regions, access to a phone or other device because the intervention was delivered virtually. They had to live within the geographical boundaries of the outpatient stroke rehab program, mentally competent to give informed consent, or had a substitute decision maker who could consent on their behalf. And they also needed to be able to understand English or have a translator. Next slide. So our outcomes were primarily patient-reported outcomes, and the selection of outcomes, as I mentioned earlier, was informed by our patient partners. And the primary outcome was looking at the risk of hospital readmission for any cause after 6 months. And our secondary outcomes included the number of hospital days and readmissions, the survival rate to first hospital and ED visit readmission, the number of ED visits, health and social service use costs from a societal perspective. And what that means essentially is that we collected all costs, regardless of who paid. So that includes people using private services as well as services covered through OHIP, physical and mental health functioning, stroke self-management, patient experience, and depressive symptoms. And for sake of time, I'm not able to go into all of the various measures that we use, but they were all reliable, valid measures that have been used in this population previously. And I'd be happy to address those, any questions about the measures later on. Next slide. So this is a very busy slide, but it gives you a summary or provides a summary of the flow through the trial. So we had 182 consecutive older adults who were with a stroke who were screened for the study, and 91% or 166 out of that 182 met all of the eligibility criteria. And out of that, 90 or 54% consented and actually entered the study. And of the 90 enrolled participants who were randomly assigned to receive either usual care or usual care plus the TCSI, 79 completed the 6-month follow-up. So our attrition rate was about 12%, which is quite low given the population and their complexity. And of the 44 participants that were receiving the TCI plus usual care, 93% or 41 received at least one visit by the interprofessional team. So a fairly high engagement rate. And over the 6 months, these 41 participants received an average of 5 visits by one of the interprofessional team providers. And the majority of these visits were offered by phone. So 81% were offered by phone and only 19% were offered by web conferencing. Next slide. So this gives you a sort of a profile of the baseline characteristics of our sample. There were 90 participants in total, and the majority were male, 60%. They were an average of 70 years of age. Over 3/4 had experienced their first ever stroke, and they were an average of 6 weeks post-stroke. They had an average of 7 chronic conditions in addition to their stroke, and were taking an average of 7 prescription medications daily. And 27% had 3 or more risk factors for a stroke. So risk factors would be things like physical inactivity, stress, family history of stroke, obesity, etc. About a quarter screened positive for depressive symptoms, almost half lived alone, and almost half had an annual income of less than $60,000. So you can see that these characteristics are fairly representative of the stroke population that one would see in an outpatient clinic. However, based on the literature, we certainly saw a population was much more frail than the average population in terms of the number of chronic conditions. So in terms of the results, as I mentioned, the primary outcome was hospitalization. And what we found was that there was no statistically significant group difference in the proportion that were hospitalized or the risk of hospitalization over the 6 months. So there was no statistically significant difference between the two groups. However, you can see that the trend did show that there was a slightly lower number of hospitalizations in the intervention group, the TCSI group, compared to the control group, as well as less likely risk of hospitalization in the TCSI group compared to the control group. But however, the number of hospitalizations was quite low. Next slide. Again, one of the secondary outcomes we looked at was the difference in proportion of ED risk or visit over the 6 months. And again, we found that there was no statistically significant group difference in the proportion with ED visits or the risk of ED visits between the two groups. And again, you can see that the trend is that there was a slightly lower use of ED visits in the intervention group compared to the control group, as well as a slightly lower risk. However, these differences were not statistically significant. Next slide. So this slide shows the difference between the intervention and the control group in the change in their health-related quality of life from baseline to the 6-month follow-up. And we used the SF12 health survey. So each of the variables are listed on the left-hand side. And on the right-hand side, you'll see that the squares, there's a line with a square, and the square represents the mean difference between the two groups with respect to each of those variables and the confidence interval for that difference. So the lines to the right of the vertical line, the red vertical line, favor the intervention. So you can see that most of the outcomes are on the right-hand side. And those lines that are not touching the vertical line are what we call statistically significant. In other words, we can say that this was not a chance finding. Then you can see that there were significant group differences in favor of the intervention in overall physical functioning, as well as 3 subscales within that domain of physical functioning, which included physical function, role functioning related to physical health, as well as vitality. So in other words, participants receiving the TCSI intervention reported greater improvements in these areas of physical functioning than those receiving usual care alone. Next slide. And again, this slide shows the difference between the intervention and the control groups in the change in stroke self-management, depressive symptoms, and patient experience from baseline to the 6-month follow-up. And you can see by the lines to the right that there were significant group differences in favor of the intervention in stroke self-management, as well as patient experience. Next slide. So this was the last variable we looked at, was the difference in costs of use and health services between the two groups over the 6-month period. And again, we found that overall, there was no statistically significant group difference between the groups. However, we did see a lower use and costs of home care in the intervention group and a higher cost of stroke care in the intervention group. The higher costs of stroke care in the intervention group were entirely attributable to the intervention. However, I do want to point out that the total cost included the cost of the intervention. So even when we included the cost of the intervention in the total cost, there was no difference between the two groups. So in summary, older persons, what we found was that older persons with stroke that were receiving the TCSI in addition to usual care reported greater improvements in physical functioning, stroke self-management, and patient experience compared to those receiving usual care alone. And these improvements were achieved without increasing total healthcare costs. Next slide. So the next component of our study was to look at the implementation evaluation. So our question was, what are the barriers and the facilitators or enablers to the implementation of the TCSI? Next slide. So this was a qualitative descriptive design, and we used data from a number of sources, including 4 focus groups. So we conducted 2 per site with a total of 12 healthcare providers. And these focus groups were conducted 6 and 14 months following initiation of the intervention. We also collected data from 6 surveys, 3 per site, with a total of 4 managers, again, 6 and 14 months following initiation of the intervention. 24 monthly outreach meetings with the intervention sites, 10 weekly or bi-monthly care coordinator meetings. So we conducted meetings with the care coordinator navigators from each of the sites, as well as other study documentation. Next slide. So this slide shows you some of the leading facilitators that we found with respect to implementation of the intervention. And the first was that the use of standardized clinical assessment tools really helped to facilitate communication and information sharing among the team. And this use of there was a set of standardized, reliable, and valid clinical tools that the intervention team used. And this helped to create a common language across the discipline. So all of the members of the team received training on the tools, how to administer them, how to interpret the scores on the tools. And this formed the basis for the discussion at the care conference and also helped to inform decision-making around care and inform the care plan for the patients. As well, the providers integrated the tools into their assessment, and they also shared the results of their assessment with the participants, which served as a motivational tool as well. The next facilitator is that we developed an alert or a set of alerts, and these were one-page documents that if the participants, for example, screened positive for depressive symptoms, dementia, or if there were concerns about their medications, then the providers would fill in this one-page document, and with the patient's permission, they would share that with the patient's family physician for further assessment and follow-up. So this was actually used as a strategy to facilitate communication and information sharing between the interprofessional team and the participants' primary care provider, which, as you know, is an indirect community stroke rehab member. As I mentioned, all components of the intervention were delivered virtually due to COVID. So obviously that was a facilitator and was the only way we could deliver the intervention during that time. The other big facilitator that came out was having a dedicated care coordinator, system navigator, and this was really key to the success of the intervention. The care coordinator was the OT, occupational therapist on the team at Hamilton Health Sciences, and it was the physiotherapist on the team at Hotel Dieu Shaver. So they played a dual role, and they made the first phone call, the first visit, and they took primary responsibility for coordinating and leading the care conferences, connecting patients to services and supports in the community. They monitored intervention delivery, ensured the information was being shared in a timely way amongst the team. They mentored and supported the team members, and they kept the team members up to date on all of the various community resources. So they created a list of community resources for the team. The other important aspect of the facilitator for the intervention was the use of SharePoint. And because the intervention was delivered virtually, the team decided to use SharePoint to securely store the study documentation and in order to enable the documentation to be shared among the team and to keep track of any changes or revisions. And the care coordinator took on that additional responsibility of setting up and maintaining the SharePoint and training the intervention team on the use of SharePoint as well. Next slide. So many of these barriers, I have to say, were also barriers related to the pandemic and changed as the study progressed. So as I said, virtual care delivery was a facilitator, but it was also a barrier in that participants and providers expressed that sometimes they had difficulty with the technology. Patients found telephone visits and providers very challenging, and providers reported that it was very difficult to implement certain aspects of the intervention, such as demonstrating exercises or conducting a home safety intervention or a medication review virtually. So that, again, served as a bit of a barrier, and certainly we were on a steep learning curve with respect to the delivery of virtual care during that time. There was redeployment of the intervention team members during the study period to deal with COVID-related issues. And that resulted in different interprofessional team members at different times being redeployed during the intervention period, which resulted in participants having limited or no access to some of the interprofessional team members, and that resulted in different exposures to the intervention across the sites. It also impacted the attendance at the monthly case conferences. And at one of the sites, we had to stop the trial a bit earlier due to redeployment of many of the intervention team members to manage COVID issues. And the result there was that some of the participants at that site were offered fewer than 6 visits and were discussed less frequently. And finally, during COVID, access to community programs and services was challenging. There were changes in the organizations that were offering services, the access to those services, the criteria for accessing, etc. So next slide. So this slide shows you that the research really had resulted in a number of impacts so to date on both practice and policy at both the local and provincial level. And this included introduction of a care coordinator navigator at one of the study sites, the addition of a registered nurse and a social worker to the team. So prior to the study, the team didn't include these providers. So at one of the sites, it's now these individuals are now part of the team. The alerts that we developed are now being used in usual practice to share information and communicate with primary care. The post-discharge follow-up was seen as so valuable and were used by providers, or currently being used for providers to reach out to patients who are waiting for admission to outpatient services, to triage those patients and to manage the wait list. The use of SharePoint for information sharing and communication was seen as very valuable and something that the team continued to use. The My Stroke Recovery Journey website that we developed in collaboration with the Central South Regional Stroke Network is now available through the Central South Regional Stroke Network for a wider audience. We certainly learned a lot about the delivery of virtual stroke care in the community that could serve as a separate presentation. And then, as Eileen mentioned, the alignment between this work and the provincial stroke CSR initiative will certainly help to inform in the future the implementation, adaptation, and scale up of this initiative. So the next steps. So the future research should really look at involving conducting a larger pragmatic trial to examine the effectiveness in more diverse geographical settings and ethnocultural populations. So we conducted our study in 2 settings in Ontario. So looking outside of those settings, we're interested in looking at the effectiveness of the intervention in those regions. As well, the next steps will examine intervention scalability. So thank you very much. And I'm going to turn it over to Eileen.
Thank you, Maureen. And I'd like to invite David, as I have a question for you, David. As you let us off to begin with, we are now 6 years later, post your event. Can you tell us from your perspective, David, how we're doing today?
Well, I think there's been major movement forward because of things like this research study, because of projects in the different units, because of councils that have been set up, and the inclusivity of and involvement of persons with that lived experience. I think there's been an incredible increase over the time. From when I think back to my experience 6 years ago, there was a whiteboard in my hospital. I'm going to call it a hotel, the hospital room again, that was the only means of communication. And that has really grown in leaps and bounds. There's this wonderful interplay now between the professional and the patient partner in developing these programs and advancing these programs. And I think recognizing the importance of the voice of the lived experience and recognizing that it has a place in the research has made a huge change in the experience for the patient and patient partners and patient caregivers. giving a weight to the voice. I know that in all of the studies that I've been involved in with Dr. Marco Reed, the patients have had an impact on the direction that the research goes. Not that they're leading it, because the professionals are doing that, but the voice is infused into how it goes forward or what direction it takes. And I think that can only make for better stroke care. I think that we're going to see in time with programs like this and research like this, that the care and the transition for those experiencing stroke is only going to grow by leaps and bounds.
Thank you, David.
So thank you. Please, if you've got any questions, you can raise your hand and we can acknowledge you that way. Certainly, you can include some questions in the Q&A, and I see that that has begun. Okay, so there's a question from Sophia. What are some of the main items included in the screening and alerts provided between the inpatient team and primary care? What are the common standardized clinical assessment tools?
Sure, I can answer that. We used a variety of tools that covered the various aspects of community reintegration. So not just physical functioning, but other aspects of community reintegration. And that included, we screened for depressive symptoms, we screened for dementia, we looked at, we had a screening tool for falls, for fall risk. We developed a stroke safety checklist to look at various aspects of physical functioning related to stroke. And we also did a medication review, and that we had a medication alert associated with that. If people were taking inappropriate medications, for example, then the alert would be triggered and sent to the family physician for further follow-up.
Thank you. We have another question from Susan. Would you be able to share the role description or job description for the RN for this outpatient stroke rehab service?
Sure, that's something I could send later on that would be happy to do.
Maybe you could send that to me, Maureen, and I can share that back to Susan.
Sure, absolutely.
Okay, and now there's a question for you, David. Thank you for the presentation. What do you think is still missing from a successful transition back to the community?
I think what's still missing is just continued education for everyone involved to continue to grow in understanding that there has to be a relationship between all partners. It's not something that's done for you. It's not something that's done to you. It's done with you. And I think that we can continue to grow in that all the time. And the more that we do activities like this, presentations like this, we're building that partnership. And I think that's an important thing to remember.
Okay. Thank you. And another question, do primary care physicians provide feedback on their observations back to the team?
Yes, actually, that's actually why we use the alerts, because it helped to facilitate information sharing and communication with the primary care provider. And although there were some barriers to that, generally speaking, it worked really well. And when the providers completed the alerts, sent it off to the family physician, oftentimes the family physician would get back to them, or they would follow up with the family physician. And so it really created that two-way communication.
Okay, we have a question from Denise Taylor. This is such exciting work, and what robust outcome measures, including cost. I was involved with the Moving On After Stroke project with Baycrest and see so many similarities in the outcome and support. Can you comment if there is any support connection between the people with stroke, i.e. group component, and what the intervention does to support ongoing exercise, as this is an issue?
Right, that's a great question. So exercise is an important component of both usual care as well as the intervention. So as I probably, I'm not sure if I mentioned this earlier, but as you probably are aware, usual outpatient stroke care, usually the duration is up to about 3 months, but our intervention actually was 6 months. So having the team work closely with the usual outpatient providers and provided all aspects of care that they would normally provide, which includes exercise. But however, once they were formally discharged from outpatient care, they continued with the intervention, and there was that transfer continuity of information between usual care and the team, who would then continue to carry out that those exercise prescriptions, and that was a big component of the intervention.
And maybe I could add to that too, Maureen, and just that we know as we think about the synchronicity with the current provincial initiative for CSR, when we look to the model of care and how we've defined that, we are looking at a longer term opportunity within those best practice definitions to the CSR initiative to extend that period beyond. So there's another opportunity there.
Yeah, and I also wanted to say that once patients were discharged from the intervention at the end of the 6 months, all along the team was working on a transition plan for that transition from completing the intervention or completing formal care to the next step, whatever that might be. So that would involve, for example, referral to exercise programs in the community, such as the Y or other programs that are out there. So we thought about transition, the team thought about transition throughout the intervention period and facilitated that transition. And that included, ongoing exercise or ongoing care and other aspects.
Okay. And there's a question from Esme. Are you also able to share the role description for the Navigator Care Coordinator?
Absolutely, and there is a Navigator Care Coordinator position at HHS. So I defer that maybe to either Eileen or Steph to comment on whether we could share that with the participants.
I'm happy to link back with Esme on what's available for sure.
Okay. So a follow-up question from Susan here. I may have missed this in your presentation, but were there other patient-reported outcomes measures or experience measures other than the survey you noted in your results?
Yes, we did some qualitative work. So we collected quantitative data using a patient experience survey, which, as I mentioned, showed greater improvements, but people reported greater improvements. But we also did some qualitative interviews with a select group of participants that were receiving the intervention to determine their experience with the intervention and any suggestions they had for improvement.
Okay, it is 9 o'clock, so we're going to have to pause the Q&A. I do just want to show again the opportunity to provide feedback. We would greatly appreciate that. Thank you very much for joining us. You can click on the link in the chat box, or there's the QR code. The next provincial stroke rounds will be held on April 5th. The topic is Fast Heroes Health Education Campaign, Children Making a Positive Impact in Stroke, and it will be hosted by the Northwestern Ontario Stroke Network. So have a great day, everyone.
Bye.